So my name is Arunaz Kumar. I'm an obstetrician gynaecologist. I work at Monash Health and Monash University as well. I look after MBBS students at Monash University, and I've looked after the obstetrics and gynecology program for undergraduates, and now I'm the MBBS evaluation lead.
My name is Atul Malhotra. So I'm a neonatologist. So I work at Monash Children's Hospital in the neonatal intensive care unit. I'm also an academic in the Department of Pediatrics at Monash University, and I'm a scientist in the Monash University Ritchie Center Hudson Institute of Medical Research space.
So I look after medical students, and as part of that, we've taught medical students about obstetric emergencies through simulation. And as part of that, we've recognized that the real gap for this sort of teaching lies in third world countries, where there are lack of facilities at sites where there may be issues that there aren't enough people available, enough resources available. And so what I recognized that we could do that sort of teaching in a setup where this is most needed. And so we thought we'll put a combined plan where we'll have obstetric and neonatal emergency training as part of simulation in a third world country.
Okay, so my interest in global health arose from our research interest, primarily neuroprotection and neurotherapy. So these are looking at newer therapies for protecting babies' brains if they've suffered an insult either in utero or after birth. In the global perspective, in the low and middle income countries, the biggest burden of disease is basically from either peripartum problems like postpartum hemorrhage or birth asphyxia. We were interested in translating our research in that setting. So I've traveled back to India in 2014 with a couple of my colleagues from our university lab group, and very soon we realized that before we actually translate any of our research methods or research therapies into that space, we needed to work on educating the ground workers, the frontline workers there to start with. That's where the idea started of education. In India and in many low middle income countries, they get trained in their medical or nursing degrees in the universities about what to expect, but there's no hands-on training which goes with it. That's where the idea of using sim and using interprofessional simulation came into, and I had the luxury of having Arunaz next to me, who was leading this work in the medical and midwifery student space in the university here at Monash. And we thought, why not we move this program in that setting of low middle income countries. And by 2016, we were running our program, which is called OneSim, which is Obstetric and Neonatal Emergency Simulation. Okay, so the idea is for us to move around those areas in the globe where they do not have enough access to hands-on clinical skills, and through simple simulation models we are able to provide that hands-on experience to them. So that's, I guess, my entry into the global health space.
So in terms of education, the first thing we need to remember is how do people learn. Now, most important aspect of that is that if we do lectures and just teach using audio, visual, etc., most people would forget what they learn. And essentially, when you do something yourself, you would retain a lot more. In fact, research says that you would end up retaining 80% if you learn by doing, which is what the objective of simulation is. So this is a more of interactive learning format where it's a learner-centered approach, and essentially the learner drives their own learning. The other thing is about interprofessional learning. So we have undergraduate course of medical students, midwifery students, they all learn in their own space, and there's hardly any interaction till the point that you start seeing conflict occurring between a midwife and a doctor, which is not an uncommon situation. In fact, part of the reason I started this workshop for undergraduates was because I was frustrated seeing that conflict, and we thought surely there has to be a better way to do this. So that's where we started the concept of interprofessional learning. Now, talking of places, whether it's in respect to Australia or India, now in Australia we already have a reasonably good setup of courses. Both Atul and I see that there's a huge scope for these programs in the lower middle income countries, which is where we want to expand upon, because those countries may not have been exposed to simulation-based learning at all.
In Australia, in a unit like ours, let's say at Monash, we would have close to 4,000 deliveries or 4,000 births every year. Not more than 5 or 10 of those births would be complicated by a significant event at birth. If you move this context into a hospital somewhere in Africa or in India, those 4,000 births would commonly lead to 5 to 10 births happening in a week, which would have similar kind of context where either the antenatal care or the postnatal or peripartum care would be to a level which would not necessarily mean a good outcome for the baby. What that means is that the resources, the education and training available for those hospitals is lacking. So very early in my time here in Australia, we've been in Australia for more than 15 years, I realized that whatever I do in Australia, it's going to be a drop in the ocean when it comes to global health or global mortality. And I think that drives us. That's important to keep it in context that we might be saving 5 to 10 babies' life with our training here when we train obstetric or medical and midwifery students or obstetric and neonatal trainees for better management of those pregnancies. But when we go to an overseas location where they are either under-resourced or poorly trained, or it's not their fault, it's just the resources are not available for adequate training, there is a gap, and we wanted to fill that gap. And I think that gap makes even more sense to us because we are migrants ourselves, so we know firsthand what actually happens in those communities. The other aspect of it is learning or knowing 2 languages. Okay, so we are in that privileged situation that we actually know 2 languages very well. So to be able to use that language to be to the benefit of someone else, I think is a really gratifying and satisfying experience. So I think that's what drives us in that we want to contribute to health outcomes not just in Australia but globally, and then being able to use a language which we know, which we are underutilizing when we are in Australia for improving health outcomes.
So what I think further to what Atul's saying, that the one thing that's really important that comes even before learning or before improving healthcare outcomes is whatever education you're providing, it has to be something that is taken in a positive manner, and learners need to be receptive to it. So you can't make a change in healthcare unless the people who you are connecting with actually are open to receiving that learning. Now, cultural connectivity in that aspect plays a very big role. So I think what Atul said was just as language, I think culture is probably beyond that as well. So language is definitely an important part of it, and obviously, as we all know, if something's not understandable to us, then it's very difficult for us to transcend that gap and be able to help out in improving outcomes. But it's also important to connect with the people who we are trying to teach. You need to achieve that basic level of cultural acceptance, which may take a bit of more of investment. So it can be possible doing that even with some other cultural communities. However, to be accepted into that culture, you will need to work towards it. But what's important is, though, that no matter what ethnicity you may belong to or what culture, it is important to connect with the audience that you are trying to teach.
I do want to say a word of caution. Frequently, people think it's cool or it's trendy to just do global health, I think that's a word of caution. You don't need to do global health because everybody is doing it. I think you need to feel passionate about it. I think, and that passion needs to come from within, but sometimes it needs to be developed, and it is hard work. You need to take all players along with you in the journey. You are not just trying to do a token charity work or a token investment of your time in global health so that it looks good on your CV or it looks good when it comes to your credentials. It's more about you wanting to really make an impact and a change. There are two ways you can look at global health as part of your careers or your work life. One is like what Arunaz is saying, is that you're doing it as a subsidiary to your main job or main interest. There are some people who have global health incorporated into their daily work life. Okay, so these are people who are working in big public health organization roles, either part of big teams in UNICEF, WHO, or wherever else, but they are mostly public health researchers or public health you can say professionals who are in that space.
And I just want to add one last thing. Each and every person can contribute to global health. So whether they recognize this or not, you don't have to necessarily, just as Atul said, you don't have to necessarily travel yourselves and be able to have the opportunity. Everyone can contribute by different ways, like making resources, online resources for teaching, or even there are other people, other organizations that we are in touch with that do charity dinners for being able to raise awareness or raise the funds for all these programs to run and to sustain. Like, it's easy to start a program and maybe just go once and run it. What's really challenging is to actually sustain it year after year in the same places and build those relationships. So I would actually put this word out there. Ask yourselves, how can you contribute to global health? I'm sure you can.